I bring greetings from the Karnataka on behalf of the Karnataka State on behalf of the Karnataka State Obstetric and Gynecological Association and our Imaging and Fetal Medicine and Genetic Committee. So this is our seventh webinar in series that we are conducting. So I welcome you all for this yet another session. This time we'll be going ahead with the topic on fetal medicine by our beloved mentor and teacher, my friend, Dr. Guru Prasad sir. At the very onset, I would like to welcome our President Sir, Dr. Durgadas Sir. Thank you for being there and thank you all the members who have joined. So before we could begin about the topic and introduction, I would ask Mr. Arun to play the welcome song.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. So today's topic is going to be on like we have moved from the nobology of the machine, then from the dating scan. Now we are on into the RPOCs. Then we are moving ahead into our more professional scans that we need to know of this era because it is all about our first trimester screening because this topic is going to form the foundation of our modern fetal medicine. So I especially welcome our president sir, Dr. Durgadas Asrana sir, and seeking his blessings for this today's evening. I request sir to bless us and give his valuable insights regarding the topic today. Thank you, sir.
Good evening, everybody. My dear Dr. Raju Giredi, the chairperson of the committee, today's speaker, Dr. Guru Prasad, President-elect Dr. Rajeshri Palladi, and all the Kasoga family. As we all know, Raju is doing a wonderful job, giving the real feast of knowledge in every session, whatever he has conducted all these months. And today's topic is one of the most relevant topic. As we know, the inverted pyramid for antenatal care. First trimester screening is gaining more and more importance with respect to ultrasound, with respect to biochemical investigations, each and every aspect, almost to the extent that it has come up to the early so anomaly scans. So many defects are, can be identified by the very advanced machines as well as the person behind the machine, just like our Raju or Guru Prasad or the team. With their expertise, we can even know so many of the anomalies. So, with these few words, I say all the best to Raju. Waiting to hear today's talk. And my thanks to Dr. Guru Prasad for coming and addressing us today. Thank you very much.
Thank you, sir. Thank you so much, sir. So today's webinar, as we know that we are going to focus on the first trimester screening because the first trimester is now no longer just about knowing or confirming the pregnancy or the number of pregnancies. Now it has become a critical window in our study of not only knowing the dating and all, but also looking into the aneuploidies, structural anomalies, and other sort of things, and also looking for the meaningful risk stratification. So, a well-known performed first trimester scan can change the entire course of our antenatal care, making this topic to be an highly relevant for clinicians, radiologists, and fetal medicine specialists over here. I thank Durgadas sir for giving his blessings. Thank you, sir. Thank you so much for joining. I thank all other Kasuga members who have joined, Paladi madam, and my society, my committee secretary, Dr. Manjunath. So I would request, because it's now my time to introduce our speaker, that is Dr. Guru Prasad sir. I request Arun to kindly share the CV. So now it's my privilege to introduce our speaker for today, that is Dr. Guru Prasad Agasimani. Um, He's a fetal medicine consultant from Davangere. He's currently the director of Guru Scan Center, Davangere. Sir is my senior, and he has also done his fellowship under my beloved Dr. Adi Narayan sir, and he is my mentor in most of my learnings. Thank you, sir, for giving us an opportunity that you giving for your time to share your knowledge in this platform. Sir is a well-known, he's a very accomplished and well-known for his clinical acumen and the systemic approach for first trimester screening and his commitment to the evidence-based fetal medicine practice. Um, so now he is here to clear our concepts, especially the practical learning points that that we are going to apply in a day-to-day life. So we are all confident that today's session will not only strengthen our understanding about but also refine the way we perform and interpret the first trimester scans. I welcome Guru Prasad sir. Thank you so much for your for acknowledging our request and giving us. We look forward to look into the topic from you. The stage is yours, sir. Sir, you can share your screen. Guru sir. Yes, sir. It is seen. You can go full. Yeah, yes, sir. We are not able to hear you, sir.
Yes, sir. Am I audible, sir, now?
Yes, sir. Yes, sir. Very good evening,
Yes.
sir. Thank
Good evening,
you.
sir. Good evening, sir.
Thank you so much. Yes, sir. You can go ahead, sir.
Good. Thank you, sir. Thank you, Raju, sir. Thank you, Durgadas, sir, for inviting me for this webinar series. I am Dr. Guru Prasad. I am practicing in Davangere Guru Scan Center. I did my fellowship under Dr. Adi Narayan Makam, sir. So today I will be talking about first trimester screening.
Sir, you can put up your video, sir.
Video.
Yes, sir.
Is it seen, sir?
Yes, sir.
Okay. Okay. So again, I would like to thank Durgadas sir and Raju Gireddy sir for this opportunity. First, I will be talking about first trimester screening. So, what is the first trimester screening involves in the recent era of fetal medicine? So, first trimester screening means one is to look for genetic abnormality in the fetus, look for anatomical abnormalities, and preeclampsia screening. I would like to clarify here is genetic abnormality means we have numerical abnormalities and structural abnormalities of the chromosomes. Numerical abnormalities include aneuploidies, polyploidies, where the number of chromosomes increases or number of chromosomes will be less. When I say screening in the first trimester, it is implied that we are screening for numerical abnormalities, that is aneuploidies and polyploidies, and not the structural chromosomal abnormalities, that is valence translocations, deletions, and duplications. And next part is anatomical abnormality and preeclampsia screening. So why we have to screen for aneuploidies? Because it is the most common cause of chromosomal abnormalities. Among the aneuploidies, trisomies are the most common one, which constitute about 59% of the total chromosomal abnormalities, followed by polyploidies. Among the trisomies, it is the trisomy 13, 18, and 21, which are most common one. And these are the things we are screening in the first trimester. As I said, among the aneuploidies, trisomies are common. Among the trisomies, it is the Down syndrome that is most common among the pregnant ladies. So incidence is about 1 in 800 pregnancy, and usually it has a long lifespan and needs lifelong support. It is poses a maximum risk because in about 50% of the Downs babies, the ultrasonography will be completely normal. So whenever we say screening in first trimester, it is implied that the main focus is to detect trisomy 21, followed by trisomy 13 and 18. So, whom to screen? It is well implied now that every pregnant lady carries a risk of having a Down syndrome baby. As the age increases, the risk of having Down syndrome babies increases. So, universal screening is the rule in the recent practice of fetal medicine. So, irrespective of the age of the mother, every pregnant lady should be screened. Coming to screening proper, what modalities we have in first trimester? We have age criteria alone, which is not sufficient. We have ultrasound criteria, which includes NT, fetal heart rate, nasal bone, tricuspid regurgitation, and ductus venosus, and placental hormones, beta HCG and PAPA, and NIPT. So I'll be covering each one separately, starting with the ultrasonography parameters. The fetus is evaluated in first trimester between 11 to 13.6 weeks of gestation between the CRL of 45 to 84 millimeter. The first thing is nuchal translucency, which is the most important backbone of the screening. So first we should know how to obtain this image. Fetus should be in the mid-sagittal position, and we have to zoom in the part of the head and upper part of the chest so that we get the image like this. And we should ensure that fetus is in the mid-sagittal position. If we see midline falx here, that ensures that it is complete mid-sagittal position, and also there should not be any bony part seen between the nasal bone and the palate. So this ensures that it is in the mid-sagittal position, and fetus should be in the neutral position. Presence of fluid between the chin and the uh, upper part of the chest ensures that fetus is in neutral position, and we should avoid flexed position and extended position as it increases or decreases the nuchal translucency value. So this image criteria is based on Fetal Medicine Foundation criteria guidelines. So we measure the NT from inner border to inner border in a straight line, and it should not be crossed like this. And it is the size that is important rather than the appearance of the NT, whether it is localized or it is septated or it covers the whole body. So it is the size or the centile which is important in screening for aneuploidies. So NT is a fluid between the fluid in the nape of the neck, usually seen in the first trimester, sometimes in the second trimester. So we should know the size of the NT should be in the centile charts. It should be put in the centile charts. NT varies from 2, 2 to 2.5. We have three centiles: fifth centile, 50th centile, and 95th centile. And the NT varies from 45 millimeter to 85 millimeter. So as we can see in euploid fetuses, most of the NT lies between the 5th to 95th centile, as compared to trisomy 21 or any other aneuploidies where NT is increased more than 95th of the centile. So we should know about the centile chart before commenting on the whether NT is normal or abnormal. So what it means NT centile, what it gives information is that So from 5th to 95th centile, about 0.2% of the fetus will have aneuploidies and 1.5% of major structural defects. And if it crosses 95th centile, that is 3.5 is the cutoff for 99 centile, irrespective of the gestational age, irrespective of the CRL. So 3.5 millimeter is the 99 centile. Up to 99 centile, that is 3.5 millimeter of NT, about 3.5% of aneuploidies are seen and 2.5% of major structural abnormalities. As the NT crosses 99 centile, that is 3.5 millimeter, which is same for all the gestational age from 45 CRL to 85. So once it crosses the 99 centile, that is 3.5 millimeter, the aneuploidy risk and major structural defects also increases exponentially. So whenever there is an increased NT, it not only signifies there is a structural chromosomal abnormality, but also syndromic associations and cause of structural abnormalities. Looking at the other side of this statistics, even though 99 centile of NT, that is 3.5 millimeter, 93% of the fetuses will be well and alive. That means whenever there is an NT, just because of the NT value, we should not discard that fetus, or we should go for a further invasive testing, so that once we rule out all the genetic syndromes, once we rule out all the structural abnormalities, about 93% of the fetuses will be going well. So that means every increased NT fetus should be given a fair chance to survive. So, following up with nasal bone, another second marker for aneuploidy in the first trimester, the image criteria is same as that of the NT, where we zoom in the upper part of the head and upper part of the thorax, and in the same image where we measure the NT, we see the nasal bone also. Nasal bone is seen as a three echogenic lines here. The first one is the nasal bone, the upper part is the skin of the nasal bone, and third is the tip of the nasal bone. So, in the echogenicity of the nasal bone should be more than the echogenicity of the skin. Then it is called as present. Even though centiles are available in first trimester also, whether it is present, whether echogenicity is more than the skin is enough for screening method. So, in first trimester, nasal bone present or absent is the only requirement for screening of aneuploidies. Coming next is the fetal heart rate. Fetal heart rate is one of the additional markers. In a normal fetus, heart rate is about 110 per minute for fifth week, and it settles by 150 per minute at 14th week of gestation. This mainly helpful in differentiating trisomy 13 and 18, because in 13 and 18 the heart rate usually above the 99 centile, ranges from 180 to 200 beats per minute, helpful in differentiating trisomy 13 and 18 rather than trisomy 21. Coming to the other markers, additional markers in ultrasonography, one is ductus venosus. It is a vessel that connects the umbilical vein to inferior vena cava for preferential flow of oxygen-rich blood to the left ventricle. The imaging criteria for this is zooming off of the abdomen, which includes the entry point of the umbilical vein and the heart. As we trace the umbilical vein, we see a aliasing pattern in the color Doppler. That is the position of the ductus venosus. Once we put the pulse Doppler there, we get a wave pattern like this, triphasic wave pattern. In euploid fetuses, this A wave, this is S, this is D, and this is A. In euploid fetuses, this A wave is always above the baseline, and it never crosses below the baseline. But in case of 50 to 60% of aneuploidy cases, this A wave touches the baseline or it reverses. Once we see the reversal of ductus venosus, we should evaluate the cardia more frequently, more adequately, so that major cardiac abnormalities should not be missed up. Coming to other next marker is tricuspid regurgitation. Imaging criteria is, once you should zoom in the thorax so that the cardia is seen in the apical four-chamber view. Use the pulse Doppler, one handle in the ventricle and other handle in the atrium, and we switch on the pulse Doppler. We get a pulse waveform like this. EA, this is atrial contraction followed by ventricular systole. There is no regurgitation of blood into the atrium. So this is a normal wave pattern. This is the tricuspid regurgitation. So once the atria contraction starts, once the atrial contraction stops, there is a ventricular contraction. So this is the area of ventricular contraction, ventricular systole. This is the regurgitant jet from the ventricle into the atria. It is crossing more than half of the systole and the velocity is reaching up to 100. So when we say tricuspid regurgitation is positive, means when the regurgitation jet crosses more than half of the systole and the velocity scale crosses 60 centimeter per second. We should be able to differentiate with the aortic flow, where the regurgitant jet never crosses 60 centimeter per second. So whenever there is a tricuspid regurgitation present, so it is seen in 1% of euploid fetuses and about 50 to 60% of trisomy aneuploid fetuses. Even though in the normal fetuses it is seen, it is normal up to 1 year of post delivery. So that is about ultrasound parameters for aneuploidy evaluation. Coming to the maternal serum biochemistry, we have two hormones now. One is free beta HCG and PAPA. So once we get the serum values of the beta HCG and PAPA, these values are converted into mom values and then they are expressed into the screening testing report. They are converted into mom values adjusted to the pregnancy of same gestation age, weight, smoking status, ethnicity, and method of conception. So what are these hormones? These are the placental hormones produced in the pregnancy. In a euploid fetus, the mom values is 1.0 for beta HCG and PAPA also 1.0. So in the euploid fetuses, the mom values of both PAPA and beta HCG is 1. In trisomy 21, 13 and 18, these values differs. In trisomy 21, as you can see here, the peak is second mom, 2 moms. And in PAPA, the in trisomy 21, it is reduced to 0.5 moms. So placental hormones, that is beta HCG, doubles in trisomy 21 and reduces to half in in PAPA, reduces to half in trisomy 21. In trisomy 13 and 18, both the values are reduced to 1/5 and 1/3 of the normal. So once we combine this ultrasonography and the serum, then it is called as a combined testing. It should be done in the every fetuses, every screening method. Between 11 to 12 weeks is the maximum difference between the euploid and aneuploid fetuses among the NT, and the serum marker difference is also greater between the 11 to 12 weeks. Beyond 12 weeks and before 11 weeks, the values may become normal even in aneuploid fetuses. So ideal time frame to combine the screening test by ultrasonography and also by serum markers is between 11 to 12 weeks to achieve the maximum benefit. That's why this concept of one-stop clinic for assessment of risk has come, Oscar, where we do scan at the scan on one day and at the same day we take the blood sample for assessment of the risk. So this is how the test report will look like. The things we should be looking at as a consultant are: one is CRL, whether it is correctly measured at the required CRL, gestational age of collection of the sample and gestational age at scan date, and age of the patient, and free beta HCG values, PAP-A values, nasal bone present or absent, NT values. So beta HCG values, as you can see here, it is corrected to mom values, that is 1.64. Normal value is 1 mom. And PAP-A, again it is corrected to 0.43 moms, that is less than the 1 mom. So this profile of beta HCG and PAP-A is coinciding with the profile of the trisomy 21, and NT value is 1.9, that is normal, and nasal bone is present. So the result has come as intermediate risk here. So that is because of the presence of beta HCG, which is more than the 1 mom, and PAP-A less than 1 mom, that is 0.43. So this is how we should be able to interpret the test results to know what is the reason for being the risk, low risk or high risk. Then, and
ನಂದು
depending on
ತಂದಿದ್ದೀನಿ
that,
ಚಪಾತಿ ಬ್ಯಾಗಲ್ಲಿದೆ ನೋಡು
and depending on that, we can uh, go ahead with the further testing, whether invasive testing or by NIPT. We can be it is helpful by knowing the
ತಗೊಬಂದೆ
values of
ನಾನು
the
ಮನೇಲಿ ಯಾರು
PAP-A,
ಇಲ್ಲ.
PAP-A and beta HCGs.
ರಾತ್ರಿ ಬರ್ತಾರೆ ನಾಳೆ ಬೆಳಿಗ್ಗೆ.
So coming to the detection rates, maternal age alone is 30%, which is very less. What we do here is the maternal age, NT and serum combined test. That is what is the combined test, it is called as. 85 to 95% detection rate with 5% false positive rate. When combined test uses nasal bone and ductus venosus and tricuspid regurgitation, the result increases to 93 to 96%, but more so, it reduces the false positive rate to 2.5%. So only NT is good, but using a nasal bone, ductus venosus, and tricuspid regurgitation, it further improves the test screening results. So once we get the results, we have three stratas. One is high risk, intermediate risk, and low risk. High risk means 1 in 250 or less than 1 in 250, and intermediate risk is 250 to 1000, and more than 1000 is called as low risk. So once the high risk comes, again first we have to do detailed anatomical survey, make sure that there is no structural abnormality, and if everything else is normal, then go for the invasive testing to rule out chromosomal abnormalities. If it is low risk, there is nothing to do, routine ultrasonography to be done and routine follow-up to be evaluated. And in case of intermediate risk, that is 250 to 1000, we can either choose for cell-free DNA testing or go for the ultrasonography for detailed evaluation. If uh, uh, detailed evaluation, everything else is normal, then you can go for cell-free DNA testing. If it comes positive, then invasive testing to be done. So this is increased NT. Till what time we can do screening? And up to 3.5 millimeter screening modality is followed by detailed ultrasonography and should be act accordingly. 3.5 millimeter is the 99th centile. So once the NT crosses 3.5 millimeter, there is no role for screening. Definitely routine detailed ultrasonography should be done, followed up with invasive testing to look for any chromosomal abnormality, genetic syndromes, or exome sequencing for single gene disorders. Still, in 1% of the fetuses, there is NT of more than 3.5 millimeter is seen. After ruling out genetic causes like with single gene disorders, chromosomal microarray, and karyotyping, should be followed up with evolving hydrops fetal demise, or any structural abnormalities in the future. Most of the fetuses, when all the genetic abnormalities are ruled out, the fetus will do fine. In some fetuses, the NT persist beyond the first trimester into the second trimester. When there is persistence of nuchal edema, the torch screening and parvovirus BU19 infection to be ruled out, and patient should be counseled for any risk of 3 to 5% risk of neurodevelopmental delay, and there is 10% risk of perinatal death. So 3.5 millimeter is the cutoff for screening, beyond which we should go for invasive testing. So that is about first trimester ultrasonography and biochemical testing. Coming to the next part, that is NIPT or cell-free fetal DNA. Cell-free fetal DNA, it is the content of the tropoblastic cells. What happens in pregnancy? The placental tropoblastic cells undergo apoptosis and they release the DNA into the maternal circulation. In the maternal circulation, there are 90% of the maternal DNA fragments will be there. In pregnancy, 10% of the fetal DNA fragments will be present. These 10% are evaluated for presence of aneuploidy in the fetus. This is one of the method of analyzing the NIPT results called massively parallel sequencing. Further methods have come which are more effective. This is important to understand how this NIPT works. See, here we have maternal DNA and fetal DNA arranged parallelly here, and these unaffected pregnancy results are compared with the test results. Once the test results are compared with unaffected pregnancy, if there is an excessive amount of DNA present in the test result, it is assumed that this DNA is from the affected fetus, and the fetus is of trisomy 21 or trisomy aneuploidy fetus. So this excess amount of DNA is assumed from the fetus. That's why it will always stay a screening test. It is not a definitive test. So limitations of NIPT is cost. It is definitely costlier than double marker and quadruple marker. Detection rate is far lesser than detection rate is for other aneuploidies is less other than trisomy 21. It is a screening test because it assumes that the excess DNA is from the aneuploid fetus. Definitely needs confirmation by amniocentesis. In case of low fetal fraction, there will be no results. So low fetal fraction, whenever the maternal obesity is there, there is increased maternal cell-free DNA, which dilutes out the fetal DNA. In case of trisomy 18, the placenta itself is abnormal. So tropoblast cells which release the cell-free DNA are dysfunctional. So whenever there is a trisomy 18 or 13, there is a chance of low fetal fraction. And when there is a when the fetus is less than 10 weeks of gestation, the low fetal fraction will be present. So when the NIPT comes as no results, we can either repeat the test at the further gestation, so that when the fetus is more grown, there is more release of the cell-free DNA, which can give us the result. Or we can go for invasive testing, or we can rely back on the combined testing followed up with the ultrasonography and quadruple markers. So as I said, it is the placental cells that will be released into the circulation, not the fetal cells actually. So whenever there is a placental mosaicism, when the placenta only is affected but the fetus is not affected, these cells are analyzed and then the results are given. So whenever there is a placental mosaicism, the NIPT test results will come positive. Again, one more reason not to rely on the NIPT test result alone, so that whenever the NIPT test result is positive, definitely go for the amniocentesis and look for the fetal, whether it is affected or not. So another next is vanishing twin. Whenever there is an excessive DNA from the dead twin, that will alter the result of the NIPT. Maternal sex chromosomal abnormalities, maternal carcinomas, where there is excessive amount of DNA from the maternal cells itself, causes NIPT false positive. So NIPT, so whenever there is NT more than 3.5 millimeter, there is no role of screening, not even NIPT double marker or anything. Definitely go for the invasive testing. Whenever there is a structural abnormality, needs 100% confirmation by invasive testing. When known genetic syndrome present in the parents, so that also requires invasive testing, and there is no role for NIPT. NIPT detection rate is about 99 to 97% between trisomy 21, 18, and 13, with very low false positive rate of 0.1 to 0.06. So mainly trisomy 21, it is the best test. It can be used as a primary screening tool or as a secondary screening tool for in an intermediate risk group of 250 to 1000 risk scoring. Coming to screening in twins, it is the most accurate is the NIPT. Second best option is the combined screening test. In monochorionic twins, pregnancy risk is calculated by taking the average risk of both the twins. In dichorionic twins, the fetal specific risk is given. Combined test, 86% detection rate for dichorionic twins and 87% detection rate for monochorionic twins with false positive rate of 5%. NIPT is the best test with 99% detection rate for trisomy 21, trisomy 13 and 18, about 93 to 95%. Beyond twins, in triplets and quadruplets, there is no role of screening. There is no role of NIPT or quadruple markers or double marker. Well done NT scan is the only way to go in the triplets and higher order pregnancies. So that is about aneuploidy screening. Coming to the preeclampsia screening in the first trimester, which is a part of screening in the first trimester, we have maternal characteristics, we have placental growth factors, uterine artery PI, mean arterial pressure, ophthalmic artery Doppler. In the first trimester, we have mean arterial, uterine artery PI, placental growth factor, and prediction rate of PE less than 34 weeks is about 94%. SFLT1 is added in the second trimester, not in the first trimester, which gives the result of about 100% for prediction of preeclampsia in less than 34 weeks of gestation. So uterine artery is imaged in the first trimester at the level of the internal os. This is the uterus, bladder, and cervix. At the level of the internal os, color Doppler is put, and the vessel is imaged, and pulse Doppler is put, and we get a waveform like this, S and D. And diastolic notch is not used for preeclampsia screening now. It is the pulsatility index of the waveform, uterine artery waveform. So both the uterine arteries are measured. Mean uterine artery PI is taken. PI of more than 90% is called as high resistance, and detection rate is 40 to 50%. Whenever there is no normograms are used, whenever there is no normograms, 2.45 mean uterine artery PI is considered as screen positive in first trimester. So next is the recent ophthalmic artery Doppler for diagnosing preeclampsia or screening for preeclampsia. This is the eyeball. When we image the eyeball, behind the eyeball we put on the color Doppler. The first vessel which pops out is the ophthalmic artery pulsating vessel. We put on the pulse Doppler here. We get a waveform like this. It has one systolic wave, second systolic wave. It is the peak systolic value of the systolic waves is important. and the ratio of second to first peak systolic value ratio is important. Whenever the ratio is increased, it is a positive predictor for preeclampsia. So both the eyes it should be measured. Mean PI is 2.0, mean PSV ratio is 0.58. When the ratio is 0.75, then mean ratio of both the eyes 0.75, it is taken as cutoff for calling it as screen positive for preeclampsia in a first trimester. Coming to mean arterial pressure, so patient should be in a relaxed sitting position. Both arms should be measured at simultaneously with correct cuff size using sphygmomanometer, electronic sphygmomanometer. Patient in a relaxing position, arms at the level of the heart. MAP is calculated by this formula. Once we get all the characteristics, we put it in the graph. This is available in perinatology.com. Once we enter all these things, maternal characteristics, which include smoking, mother of the patient had preeclampsia, chronic hypertension, diabetes, SLE, APLA, nulliparous or paras. We have mean arterial pressure, mean uterine artery PI, and PLGF and PAPA values. So once we put on all this data into the software, we get high risk or low risk. Whenever there is a high risk of more than 1 in 100, it is called as high risk, and aspirin is started at 12 to 36 weeks of gestation. Low risk is less than 1 in 100, again re-evaluated in the second trimester at 22 weeks along with the other SFLT1 and uterine artery PI. If it is still high risk, then you can go with the aspirin, and if it is low risk, monitor routinely. So that is about the preeclampsia screening. Coming to the important part of anatomy screening, once we see all the once we do all the NT screening for chromosomal aneuploidy, it is mandatory we should look for the any major structural abnormality, any major structural abnormality which will be easy to detect. Uh, this is a these are the few examples I will be taking, which will be easy to detect in a routine NT scan. So one of those markers is the open spina bifida. So this is a normal picture in the mid-sagittal section. According to FMF guidelines, perfect mid-sagittal section, nasal bone is present, NT is present. Looking at the posterior brain structures here, we have thalamus, midbrain, brainstem, posterior border of the brainstem, choroid plexus of fourth ventricle. Between these two, it is called as intracranial translucency, and the choroid plexus to the occipital bone, it is called the cisterna magna. So we have three spaces and two lines. So when we do routinely NT scan with this definitive image, any abnormality we can easily pick it up here. As you can see here, there is only two spaces and there is only one line separating the two spaces. So that means the brainstem and to brainstem occiput ratio, the brainstem has moved posteriorly, so that brainstem to occiput ratio has become more than 1. That is one of the marker for open spina bifida. Maxillo-occipital line, the line between the upper part of the maxilla to the occiput, the junction between the midbrain and the thalamus lies above this line. In case of open spina bifida, the junction of the midbrain and brainstem lies below this line. So basically the brain structures are posteriorly displaced. So it is one of the important markers for open neural tube defect, which can be easily found out when if you are doing good NT according to FMF guidelines. So once it is seen, we look at the nasal, we look at the spine, look for the any open neural tube defects. This is a case of open neural tube defect. Again, in the same mid-sagittal section to look for NT, we have displaced anatomy in the posterior cranial fossa or brain structures here. Rather than displaced, it is distorted anatomy. So once that is there, we should look for carefully at any occipital damages here. As you can see, there is a defect in the occipital bone and the brain's structures are herniating through it. So this is a defect where the brain structures are herniating through it. So it is a case of occipital encephalocele, which can be detected in the mid-sagittal section. Another lethal anomaly is alobar holoprosencephaly. Again, maintaining the correct mid-sagittal section in the NT scan, we can see the midline forks. Once we are not able to see midline forks in the sagittal section, we look at the coronal transverse section to see whether there is a presence of forks cerebri present or not. Here we can see there is absent falx cerebri and the ventricle, there is single ventricle and there is fused thalami. So one of the lethal anomaly which can be easily detected is alobar holoprosencephaly in the first trimester. Again, in the mid-sagittal section, the chin is receding back compared to the nasal bone. So case of micrognathia, this will direct the investigation further rather than going for routine trisomy screening. If these kind of things are picked up in the early first trimester, we can directly go for invasive testing to look for any syndromic association, or further counseling of the patient is helpful in the early trimester. As I said here, routinely if we are doing tricuspid regurgitation, just putting up one color Doppler, we can see beautiful inflows and outflows in the heart. We have two inflows into the ventricle, which is seen in red, and two outflows, that is pulmonary artery and aorta, forming an V. So this is the normal anatomy of the heart, four-chamber view anatomy of the heart, which rules out the valvular pathologies and four-chamber view abnormalities. So in the four-chamber view abnormality, this is a case of complete atrioventricular septal defect. As we can see here, there is no crux. There is a large VST. So it is one of the complex anomaly which can be easily detected in the first trimester, routinely while doing tricuspid regurgitation assessment. Once this AVSD is seen, it is a case of it is a complex cardiac anomaly, requires multiple surgeries, and it is associated about 50 to 60% with Down syndrome. So most of them major anomalies can be terminated in the first trimester itself. Again, as you can see here, there is only one inflow into the this is the four chamber view of the heart, this is the spine, this is the aorta, this is left side and this is right side. As you can see, there is only one blood flow going into the ventricle on the right side. The left side ventricle is not seen, the blood is not flowing into the left ventricle. And the outflow also, there is only one vessel coming out of the ventricles. As you can see, there is a slight reversal in the other vessel. So it was a case of hypoplastic left heart syndrome. Again, major structural abnormality with very poor prognosis, can be opted for termination in the first trimester itself. More complex anomalies can also be diagnosed in the first trimester, like this transposition of great arteries, where we can see parallelly arranged vessels coming out of the ventricles. So case of transposition of great arteries. So again, four chamber view of the heart. Heart is pushed to the right side and left side of the thorax is occupied by the stomach. In the sagittal section, as we can see here, the stomach is into the thorax. Into the thorax, this is the diaphragm, stomach into the thorax. Case of congenital diaphragmatic hernia. So surrogate markers of upturned superior mesenteric artery going into the thorax implies that mesentery of the intestine are also into the thorax. So simple evaluation of the upper limbs and lower limbs. This is a case of radial ray syndrome where there is absent radius and absent thumb, opted for termination in the first trimester. case of acrodactyly, where there are fused upper limbs, there is no thumb, absent thumb and fused upper limbs, fused fingers and absent thumb. So once we diagnose these kind of anomalies in the first trimester itself, patient counseling becomes easy, and if they are willing to continue the pregnancies, the mode of testing for this fetus differs. So case of acrodactyly, case of polydactyly, here bilateral absent femurs. These are all, most of them are non-lethal forms of anomalies. Case of cynomelia, where there is a fused lower limbs, sacral agenesis. To conclude this first trimester screening, the best time to screen is the first trimester, which gives us optimum time for decision. Best modality is the NT scan with anatomy screening and NIPT. Second best option is the combined screening with NT scan and double marker. PE screening should be included in every scan. Every pregnant woman should be screened. So I would like to thank again Raju sir and Durgadas sir for giving me this opportunity. Thank you, sir.
Thank you, sir. Thank you so much. So before we could end up session, we shall take up some few questions. Dr. Veena has asked to please explain once again. Madam, can you please specify what is that you wanted to know from sir? And someone has asked to share the screening PPT slide.
Sir.
I can find only these two questions over here, but Dr. Veena has asked for, I don't know, sir, what she meant or what exactly she. Bella sir, thank you, sir. Sir has told a fantastic presentation. Okay, Manjunath sir, excellent presentation. I would like to call upon our secretary, Dr. Manjunath Thukeri, to share his few insights on the topic. He is also our colleague and Guru Prasad sir's close friend. Manjunath, can you unmute and say, add to some of
Yeah,
the points?
yeah, very good evening to everyone. First of all, I would like to thanks and congratulate Dr. Guru sir for a wonderful, crisp and clear presentation on first trimester screening, which nowadays has become like one of the universal screening, like how we screen for the HIV, HPSCG, VDRL in the antenatal patients. This first trimester screening, in fact, I will say it like a combined first trimester screening as a universal screening for all the antenatal women, and I guess our all women deserve this. I'm audible?
Yes, sir. Yes,
Yes,
sir.
yes, yes,
Yeah.
very much.
The only thing what I want to tell is like whenever we do a combined first trimester screening, first thing and foremost is we should select an appropriate lab. Secondly, we should select a good NT scan, which has to be done as per the FMF guidelines. And thirdly, many of the times we see once a patient comes back to the report, we just see whether it's a low risk, high risk. We tend to forget to see those numbers in between the numbers, which Guru sir rightly said about the PAPE, beta HCG, what to explain to them, because many of the times when the PAPE is low, beta HCG is high, there is a very high probability that these babies are at risk for developing FGR, preeclampsias. And once you start them on the prophylactic echo screen, do a follow-up properly, do a regular growth scans, and eventually if patient develops a hypertension disorders in pregnancy, also they accept that morbidity, that it was told to them. And many of the times when the PAPE is very low, less than 0.2, even we have to explain them that there can be a spontaneous miscarriage or spontaneous IUDs in future of the pregnancy in a sensible way. So these are the few points very well we have to tell. And many of the times when we give the report has a nasal bone hypoplastic or absent, many of the times in the report, it goes as a nasal bone status present. So then it comes as a low risk. And then the patient says like you said like this report says normal. So these are very much important points, which I feel like one interpretation of the dual marker or double marker report is also very important. And NIPT has to be used very cautiously. NIPT is only a screening test. It is not a diagnostic test. a positive NIPT has to be confirmed with a invasive testing, and a negative NIPT does not rule out that it is not a Downs, because I had both the cases. I had a NIPT positive, baby came out to be a normal. Absolutely. I had a negative, I have a low risk NIPT, and baby turned out to be a Downs. So counseling is very important. And one more thing, triple marker is a obsolete. It should not be done. That's all. Yeah. Thank you.
Yeah,
Thank
Manjunath, can you explain again about the PAPE? Can you just tell the PAPE
The
information?
PAPE
Because
is a glycoprotein which is produced by the placenta
I
cell.
know that I'm not.
So
I
the,
want to know. You
one should
said the
the
levels.
normal the normal level of the PAPE is what is point less than 0.48 or 0.45 moms. More than 0.48 or 0.45 moms. If less than 0.48 or 0.45 moms, then these are the patients at risk for developing hypertensive disorders, FGR, and eventually probably a preterm labor iatrogenically. So when it is less than 0.2, the studies have shown that they are at the risk for sudden miscarriages, sudden IUDs. So if you find a low PAPE on a dual marker, these are the patients which strictly requires a close antepartum fetal surveillance in terms of growth and Doppler assessment.
Thank
yes.
you. Thank you. Dr. Guru Prasad,
Thank you.
I have a simple question on
Yes, sir.
twin pregnancy.
Yes, sir.
How exactly and when exactly you advise NIPT?
Sir, it can be used as a routine screening also, sir. First, as a first trimester screening, or it can be used as a secondary screening tool in case of intermediate risk in the double marker. After that, you can go for NIPT testing, sir.
Okay. And if there is a one twin IUD,
Yes, sir.
how many days we have to wait for,
Sir,
if at all?
one twin IUD to the for the fetal cells to clear out, it requires 6 to 8 weeks, sir.
Okay. Thank
Once the IUD is confirmed after 6 to 8 weeks, you can go ahead with NIPT.
Thank you so much.
Thank you, sir. Thank you for joining, sir. Belat, sir. Thank you, sir. Sir, one of the madams, they wanted to know about the spina bifida marker slide. If you can share it again, that you had shown. Many praises, sir, for your wonderful presentation.
Thank you, sir. Thank you.
Many praises in the chat box. It was excellent, sir.
So this is the normal twin, normal fetus in the mid-sagittal section. So midline falx, thalamus.
Yes.
This is the brain stem. This is the posterior part of the border of the brain stem. This is the space which is called as intracranial translucency. This is the choroid plexus of the fourth ventricle, and this is the cisterna magna. This is the occipital bone. So one hypoechoic, two hypoechoic, three hypoechoic regions, two hyperechoic lines. So whereas in this there is loss of one hypoechoic space, either it can be cisterna magna or intracranial translucency. So only two spaces are there, and this uh, normally brainstem and to brainstem ratio is less than 1. So brainstem is smaller to brainstem to occipital bone ratio. In case of open spina bifida, the brainstem is pushed posteriorly towards the occipital bone. So it appears that the brainstem is longer than the brainstem to occipital bone ratio. So this is the ratio of more than 1. It is a positive marker for open spina bifida. And maxillooccipital line, the junction of brainstem, midbrain and brainstem, the thalamus and midbrain junction will be above this line. In case of open spina bifida, this junction will be below this line. So basically, all the structures are pushed posteriorly towards the occipital bone. So that is it.
Yes, sir. Yes, sir. Thank you, sir.
Thank.
Um, no, No more questions, sir. All wonderful session, excellent presentation, excellent message to the delegates. Dr. Durgadas sir has messaged, thank you, sir. Excellent message to the delegates and thank you.
Thank you, sir.
Okay. Bella sir has asked that we will go for a workshop. Thank you, sir. With your blessings, we will go ahead, sir.
At
Thank
our
you.
place, man, not at Raisur, not on webinar. I
Yes.
want live
Yes, sir. Sure, sir.
because we
Modern,
want
sir.
to see you all
Yes.
I mean, physically.
Yes, sir. Manjunath will lead, sir. Will definitely will go ahead, sir. Yes, sir.
Thank you so much. Hope you
Thank you, sir.
catch him. Hope you catch him.
Yes, sir. Yes, sir. He's a busy man, sir. Yes, sir. We will catch him, sir. He's. We are lucky that he has joined today. Yes, sir.
Thank you. Thank you.
Thank you so much, sir. So, okay, sir. On behalf of Karnataka State OBGY Society and especially our image from our imaging sciences and the genetic committee, I extend my sincere thanks to Dr. Guru Prasad Gasimani for a clear, insightful, and a practical, relevant session which sir has taken on first trimester screening, which is a very important one, because our foundation begins more exactly from here. You took us from understanding what an aneuploid is, and you took us looking into the screening test modalities, including the double marker and the NIPT, and relevant questions asked regarding NIPT. You cleared our doubts, and also mesmerizing your first trimester images that shown the important things that we can also detect and you should not miss. Uh, and you have enriched our understanding, so it will certainly influence our day-to-day practice. I would also like to thank our office bearers from the committee, Manjunath sir, and all the beloved Kasoga members who have joined. And also, I would like to thank the technical team, Mr. Arun, for ensuring the smooth conduct of today's webinar. Most importantly, I thank all the delegates who have joined in large numbers, and thank you for your active participation. So today, with this, we conclude today's session. Wishing everyone a pleasant evening. Thank you, everyone. Thank you,
Thank you.
Guru Prasad sir.
Thank you, Raju sir.
Thank you, sir.